Welcome back to the Deep Dive. This is where we take all the knowledge you've gathered, your articles, your research, and we drill down to give you that ultimate shortcut to being, well, truly well-informed. Last time, we set the stage for peptic ulcer disease, or PUD, covering what it is and what the main causes are.
That's right. We really established that, for the most part, PUD is driven by two things: the bacterium Helicobacter pylori and, of course, the very common use of nonsteroidal anti-inflammatory drugs, NSAIDs. It's not just about stress or spicy food.
Exactly. So today, we're making a shift. We're going from the what and the why to the how. And if you're the learner trying to really get your head around the clinical pathway, from the moment a patient first presents to the point they're actually treated, then this deep dive is for you.
Yeah, our goal today is to map that entire process: the assessment, the gold standard investigations that doctors use, and then the different layers of management, from medication all the way to surgery.
And understanding this is so important because, as we're about to see, the patient's symptoms are really the roadmap. They tell you everything.
They absolutely do. The symptoms dictate whether you can start with a simple test or if you need to jump straight to something much more invasive. We're really going to give you that framework for thinking through a clinical evaluation.
Okay, so let's start that journey right at the beginning. The diagnosis, as with most things, starts with a good history and a physical exam. Before we get to any of the fancy tech, what are the sort of core clues, that trio of symptoms that makes you think, okay, this could be PU?
Well, the symptoms can be really variable and honestly pretty nonspecific. They could point to a lot of things. But the core trio that really raises your suspicion is, first, that persistent epigastric abdominal pain. That's the discomfort right in the upper middle part of the stomach.
Right below the sternum.
Exactly. And that's paired with early satiety and a feeling of just uncomfortable fullness after eating.
And early satiety just means you feel full way too quickly, right?
Precisely. You take a few bites of a meal you'd normally finish and you just feel completely full, so you have that baseline discomfort. But the real aha moment, the thing that really helps distinguish PUD from, say, just general indigestion, is how that pain behaves around food.
This is the critical distinction. This is the piece of information everyone needs to get.
Absolutely. The timing of the pain tells you so much because the mechanism is completely different depending on where that ulcer is.
Okay, let's start with the gastric ulcer, the GU, the one that's actually in the stomach itself.
For a gastric ulcer, the pain typically gets worse. It increases, say, 15 to 30 minutes after the patient eats. And if you think about the physiology, it makes perfect sense.
Because food hits the stomach, and the stomach's job is to pump out acid.
Right. It starts churning and releases all this strong acid and pepsin to start digestion. Now, if you have an open sore and ulcer on that stomach wall, that rush of acid is going to hit that raw spot directly, and that causes a pretty sharp increase in pain.
And of course, if eating causes you pain, you're going to start avoiding it. What's the behavioral result we see in these patients?
It's a classic pain avoidance behavior. They subconsciously, and sometimes very consciously, start to eat less because they learn that eating leads to pain. This is so common that it often results in, significant and unexplained weight loss, which becomes a really critical part of their history.
That's a powerful connection. The body is essentially driving the patient to avoid food just to avoid pain. So now let's flip that. What about the duodenal ulcer, the DU, the one that's just past the stomach?
This is where it gets a little counterintuitive. For a duodenal ulcer, the pain actually gets better when the patient has a meal.
It decreases. Why?
So when food leaves the stomach and enters the duodenum, it's mixed with acid, yes.
Okay.
But the food itself, the bulk of the meal, acts like a temporary buffer. It physically shields the duodenal lining from the acid for a little while. And on top of that, food entering the duodenum triggers the pancreas to release bicarbonate, which actively neutralizes the acid.
So it's a temporary relief. It lasts until the food moves on, and then the acid is left behind to irritate the ulcer again.
Precisely. The pain might come back a couple of hours later. Sometimes it's bad enough to wake them up in the middle of the night. But because eating gives them that immediate, significant relief, the patient learns that food is their friend. It's their medicine.
Wow, so the body is essentially self-medicating. The patient is driven to eat more just for that temporary relief, even if it's not helping the ulcer long term.
It's a real irony, isn't it? That drive for relief can lead them to eat more often, maybe grab high-calorie snacks, and that can actually lead to noticeable weight gain. And that difference, weight loss with gastric ulcers versus weight gain with duodenal ulcers, that is probably the single most valuable clue you have before you even think about ordering a test.
A true clinical pearl. But, sometimes the symptoms are more than just discomfort. They're emergencies. Let's talk about the alarm symptoms, the red flags that mean you'd investigate immediately no matter how old the patient is.
Absolutely. These are the symptoms that tell you a complication might be happening, or even something more sinister like a malignancy. If you see these, you skip the normal process and go straight for an EGD.
And those are?
So you're looking for 1, anemia, which tells you there's been chronic blood loss, 2, melena. And that's the very specific term for that dark, tarry black stool. It's not just dark, it's digested blood, which tells you the bleeding is high up in the GI tract.
Okay, what else?
3 is hematemesis. That's vomiting either bright red blood or what we call coffee ground material. That's an acute bleed. And then 4 is unexplained, significant weight loss. And finally, recurrent or intractable vomiting.
So those 5 symptoms are the ones that scream, stop, don't pass, go directly to the scope.
Yeah.
We're not just thinking about a simple ulcer anymore. We're worried about major bleeding or perforation or even cancer.
Correct. If you see even one of those, that patient needs an EGD as soon as possible, not in 6 weeks.
And just quickly, on the physical exam, while the story is everything, what might you actually find when examining an uncomplicated case?
Honestly, the physical exam is often less revealing than the history. The most common thing you'll find is some localized epigastric tenderness when you press on that area. If there's been chronic bleeding, you might see signs of anemia, like paleness. But for a typical uncomplicated PUD, it's usually just that mild tenderness in the upper abdomen.
So the history and symptoms are pointing you squarely at PUD. Where do you go from there to get a definitive proof?
Now we turn to technology. And the definitive test, the gold standard, is the esophagogastroduodenoscopy, or EGD. There's really no debate. It's the most accurate tool we have, with a sensitivity and specificity up around 90% for finding both gastric and duodenal ulcers.
And the EGD, just to be clear for everyone, is where a flexible scope with a camera is passed down the throat into the stomach and the duodenum. It's invasive, but you get to see everything directly. So what are the official guidelines? When do clinicians have to do this procedure?
The guidelines are really clear, and they're designed to catch serious problems early. There are basically 2 main triggers. First, any patient over the age of 50 who comes in with new, unexplained dyspeptic symptoms, so new indigestion or pain, should get an EGD.
And why is 50 the magic number?
It's a pragmatic cutoff. It's the age where the risk of something else, particularly gastric cancer, starts to rise enough that you want to take a look inside. You don't want to assume it's a simple ulcer and start treatment. A 25-year-old with new pain, we might try medicine first. A 55-year-old, we want to see what's going on.
Yeah, I'm guessing the second trigger goes back to those red flags we just talked about.
Exactly right. The second trigger is anyone at any age who presents with those alarm symptoms: anemia, melena, weight loss, vomiting blood. A 25-year-old vomiting blood is getting an EGD immediately. Those symptoms mean something urgent is happening.
It really sounds like the EGD is the go-to because you can see the problem and potentially even fix it, like stopping a bleed all in one go. Is there any situation where you'd use an older test like a barium swallow?
It's pretty rare. EGD is always preferred because you can see everything and, crucially, take a biopsy. But in very specific cases where an EGD is just too risky, maybe the patient has a severe neck problem or a bleeding disorder, then a barium swallow might be an alternative. But it's a big step down. It only gives you indirect evidence, and you absolutely can't take a biopsy.
Okay, let's move over to the lab. What basic blood work needs to be done to get the full picture?
You always start with the basics to see if there are any systemic effects. So a complete blood count is non-negotiable. You're mainly looking for anemia, which points to bleeding. You also need liver function tests, LFTs, to check on the liver and bile ducts. That's a key part of the differential diagnosis, ruling out other causes of upper abdominal pain.
And you mentioned 2 specific enzymes that are really critical for that differential.
Yes, probably the most important initial labs are amylase and lipase levels. We always order those because they are very quick indicators of problems with the pancreas.
So why are we worried about pancreatitis if we're thinking PUD?
Because it's a major mimic. Acute pancreatitis can present with severe epigastric pain that radiates the back, and it can look exactly like a complicated ulcer. But the management is completely different. Pancreatitis is all about supportive care, often in the hospital. So, elevated amylase and lipase levels immediately steer you away from the stomach and toward the pancreas. It prevents a very dangerous misdiagnosis.
And what about that really specialized test? The one for massive, unstoppable acid production?
Ah, yes. That would be the serum gastrin level. This is a very specific test. You only order it if you have a suspicion of something called Zollinger-Ellison syndrome, or ZES.
Let's just touch on ZES for a second. I think for the learner, Hearing about a tumor that causes stomach acid sounds a bit like science fiction. How rare is this?
It is thankfully very, very rare. ZES is caused by a tumor, a gastrinoma, that produces the hormone gastrin. Gastrin is the hormone that tells your stomach to make acid. So if you have a tumor pumping it out 24/7, you get massive, unrelenting acid secretion.
And that leads to really severe ulcers.
Severe, multiple ulcers, often in weird places, and they just don't heal with normal treatment. So if you have a patient whose ulcer isn't healing despite high-dose PPIs, ZES gets on your radar, and that's when you check the gastrin level. It's a key test for refractory disease, but not for your average PUD workup.
All right, let's focus on the main culprit, H. pylori. If a patient has an ulcer, we have to know if this bug is the cause. What are the best non-invasive ways to check for it?
We have several really good non-invasive options. There's serology, which is a blood test for antibodies, though that can stay positive even after the infection is gone. There's a stool antigen test. But really, the most effective and versatile test, the one with the highest sensitivity and specificity for an active infection, is the urea breath test.
The UBT.
Yeah.
Let's unpack the science behind that, because it's
Yeah.
pretty clever. Why is it so good for confirming an active infection, and why is it also the test you use to prove you've cured it?
It all comes down to the unique way H. pylori survives in the stomach. The stomach is incredibly acidic, so to live there, the bacterium produces a special enzyme called urease. And what urease does is it breaks down urea into ammonia and carbon dioxide. The ammonia neutralizes the acid right around the bacteria, creating a little protective shield.
So the test isn't looking for the bacteria itself, it's looking for that urease enzyme.
Exactly. The patient drinks a liquid that contains a special kind of urea with a labeled carbon atom. If H. pylori is present, its urease immediately breaks that urea down. The byproduct, that labeled carbon dioxide, gets absorbed into the blood, goes to the lungs, and the patient breathes it out. We just collect their breath and measure the amount of labeled CO2. If it's there, the active enzyme is there, which means active H. pylori is there.
That is genuinely smart. And that explains why it's perfect for checking after treatment, too.
Yes. It's vital for confirming eradication. After the patient finishes their antibiotics, if the treatment worked, the bacteria are gone, so the urease is gone. The test will be negative. We just have to wait 4 to 6 weeks after they stop the medicine to do the test to make sure all the drugs are out of their system so we don't get a false result.
Okay, now, if we're already doing an EGD, we can take a piece of tissue. Why isn't an invasive biopsy and culture the first choice for diagnosing H. pylori?
For a brand new diagnosis, a culture is usually overkill. It's an expensive, slow process. It takes special lab conditions to grow the organism. The non-invasive tests are just so much cheaper, faster, and they're accurate enough for that initial diagnosis.
So when would you absolutely need to do a biopsy?
You reserve the biopsy for 2 main situations. First, if the initial first-line antibiotic treatment fails. And second, if you have a high suspicion of antibiotic resistance in your area. If you think resistance is the problem, you need the tissue so you can do susceptibility testing to see exactly which antibiotics will kill that specific strain of H. pylori. That guides your next choice of therapy.
And if you do need a biopsy, is one little snip of tissue enough?
No, absolutely not. To get good sensitivity, you need to take biopsies from at least 4 to 6 different sites in the stomach. The bacteria aren't evenly distributed, so if you only take one sample, you could easily miss it and get a false negative.
Last thing on diagnostics, imaging. We see CT scans used for all sorts of abdominal issues. Does a CT scan of the abdomen play a big role in diagnosing the ulcer itself?
This is a really clear point for the learner. A CT scan has very limited value in diagnosing PUD itself. An ulcer is just a shallow break in the lining of the stomach. A CT scan just doesn't have the resolution to see that reliably. The EGD is the tool for that job.
But it's not useless in this context. Where does the CT scan really shine?
It's invaluable for diagnosing the complications of PU. If you suspect a patient has a perforation where the ulcer has burned a hole right through the stomach wall, the CT scan is fantastic. It can show free air in the abdomen, which is a dead giveaway. It's also great for diagnosing a gastric outlet obstruction where you can see the stomach is all swollen and blocked up.
Okay, so we found the ulcer and we know the cause. Now it's time for management. Let's start with the cornerstone of treatment, turning down that acid.
Right. The core of medical management is using anti-secretory drugs. The goal is to reduce the acid so the tissue can finally heal. We used to use H2 receptor antagonists, but now proton pump inhibitors, or PPIs, have almost completely taken over as the primary therapy for PUD.
And why is that? What makes PPI so much better than the older drugs?
It really comes down to how well they block the acid and for how long. PPIs provide a much more powerful and sustained reduction in acid. They work by irreversibly blocking the final step in acid production, the proton pump itself. This leads to much faster symptom relief and significantly higher ulcer healing rates compared to the older H2 blockers.
Makes sense. The less acid, the faster the healing. But there are always trade-offs, especially with long-term use. We have to talk about the potential downsides of PPIs.
We do, and it's an important one. The source material is clear that long-term, high-dose use of PPIs can increase the risk of bone fractures, especially hip fractures. It's thought to be related to how the body absorbs calcium.
So for a patient who needs to be on them for a long time, what's the plan?
The management has to be a bit more holistic. You need to think about incorporating calcium supplements and monitoring their bone health. It's a reminder that treating PUD isn't always just about the stomach.
Let's get specific now and talk about managing the cause. If the ulcer is clearly from NSAIDs, what's the first and most critical step?
The first step is simple in concept but can be very difficult in practice. You have to stop the NSAIDs. If the patient absolutely cannot stop them for another medical reason, then the goal is to get them on the lowest possible dose that still works, ideally with some form of protection.
Are there other medications that you'd also look at stopping?
Yes. You'd want to discontinue other drugs that can damage the stomach lining or increase bleeding risk. That list includes corticosteroids, bisphosphonates, which are used for osteoporosis, and of course, any anticoagulants, any blood thinners. An ulcer in a patient on blood thinners is a recipe for a major bleed.
What about for that patient who has to stay on their NSAID? Is there something you can give them to prevent another ulcer?
Yes, there's a strong option for prophylaxis. We can use prostaglandin analogs, specifically a drug called misoprostol. Prostaglandins are natural chemicals that protect the stomach lining, and NSAIDs work by blocking their production. So misoprostol is basically a synthetic replacement, restoring the protection that the NSAID took away.
Okay, now for the big one, H. pylori. Once you've confirmed it's there, you move to eradication. What does that first-line treatment look like?
The standard approach is called the triple regimen. It's a combination of 3 drugs, 2 different antibiotics, and 1 high-dose PPI. A very common example would be pantoprazole, which is a PPI, plus the antibiotic clarithromycin, and then a second antibiotic, either metronidazole or amoxicillin.
And how long does a patient have to take this pretty intense cocktail of drugs?
The typical course runs for 7 to 14 days, and it's absolutely crucial that they finish the entire course, even if they start feeling better, to make sure we kill all the bacteria and prevent resistance.
Let's dig into that a little. Why is the PPI included with the antibiotics? We know it helps heal the ulcer, but what's the synergy? How does it help the antibiotics work better?
The synergy is absolutely critical to the success of the treatment. The stomach is a very harsh, acidic place, and that acid can actually break down some antibiotics, making them less effective. The PPI dramatically reduces the stomach's acidity. It creates a much more neutral, less hostile environment.
So by raising the pH, you're basically protecting the antibiotics.
Precisely. For an antibiotic like clarithromycin, lowering the acid level increases its stability and allows it to reach the stomach lining in a higher, more effective concentration. It boosts the kill rate significantly. The 2 drug classes work together much better than either one would alone.
That brings up the issue of antibiotic resistance. How much does the local resistance pattern in a particular city or country affect which antibiotics you choose?
It's a huge factor. You have to take local antibiotic resistance into account. For instance, in places where we know there's high resistance to clarithromycin, say over 15 or 20%, the guidelines suggest skipping that clarithromycin-based triple therapy entirely.
So you'd go straight to something else?
You'd go straight to a bismuth-based quadruple therapy, even for the first try. So yes, knowing your local resistance data is absolutely essential.
And if that first-line triple therapy doesn't work, which you confirm with that UBT a month or so later, what's next?
Then you escalate to the quadruple therapy. This usually involves a different set of antibiotics and always includes bismuth. Bismuth seems to have some direct antibacterial effects, and it also helps protect the stomach lining. It's just a more powerful second-line attack designed to overcome any resistance.
But even with these powerful drugs, sometimes an ulcer just won't heal. This is what we call a refractory disease. What's the official definition of a refractory ulcer?
A refractory ulcer is defined as one that's over 5 millimeters in diameter that shows no signs of healing, even after 8 to 12 weeks of continuous high-dose PPI therapy. So if you've been treating it aggressively for 2 or 3 months and that crater is still there, you're dealing with a refractory case.
And that's when you have to play detective. Before you even think about surgery, what are the common reasons an ulcer might not be healing?
You have to rule out a few key culprits. The most common is a persistent H. pylori infection. Either the treatment failed or the patient didn't take all the pills. Second is continued NSAID use. You have to ask them again. Then there are other major illnesses like kidney disease or diabetes that can just impair healing in general. And finally, you have to reconsider the really serious things. Could this be a gastrinoma, ZES, or could this non-healing ulcer actually be gastric cancer?
So surgery is really the absolute last resort. When do you finally make that pivot and say, okay, medical therapy isn't working, we need to operate?
Surgery is indicated when the patient is truly unresponsive to all medical treatment, when they're proven to be dangerously non-compliant, or if they're at a very high risk of major complications like recurrent, life-threatening bleeds that you can't control with medicine.
And if you get to that point, what are the surgical options? What's the goal of the surgery?
The goal of the surgery is to permanently reduce the stomach's ability to produce acid. The two main options are a vagotomy or a partial gastrectomy.
A vagotomy. How does cutting a nerve reduce stomach acid?
The vagus nerve is the main nerve that stimulates acid secretion in the stomach. So a vagotomy involves surgically cutting the branches of that nerve that go to the stomach. It's like turning down the main acid switch. It dramatically reduces acid production. The only downside is it can also slow down stomach emptying, so it's often paired with another procedure to help with drainage.
And a partial gastrectomy.
Yeah.
That sounds more drastic.
It is. A partial gastrectomy means surgically removing a part of the stomach. This not only removes the ulcer itself, but it also removes a large portion of the cells that actually produce the acid. It's a much bigger operation, usually reserved for the most difficult cases or when there's a concern for cancer. All right, this next section is so important for critical thinking. I mean, for the learner, real expertise isn't just knowing what PUD looks like, it's knowing what else looks just like PU. We have to be able to tell it apart from things that are benign all the way up to things that are immediately life-threatening.
Okay, so let's start with the close neighbors, the conditions that cause pain in that same upper abdominal area.
The most obvious one is gastritis. This is just inflammation of the stomach lining. It can be caused by alcohol, infections, and immune response. And clinically, it presents almost identically to PU'd upper abdominal pain, nausea. The key difference, really, is that gastritis is surface-level inflammation, whereas an ulcer is a deep erosion that goes into the muscle layer.
And you can't really tell that difference without looking.
Not for sure. Often, only the EGD can definitively separate the two.
What about GERD, gastroesophageal reflux disease? So many people have it. How does that feel different from PER?
GERD usually has a slightly different flavor. The classic symptom is that retrosternal burning sensation we call heartburn, which can feel like it's rising up into the chest. Patients might also complain about regurgitating sour fluid. So while the pain can be in the same general area, that primary complaint of burning and regurgitation points you more toward reflux than a fixed ulcer.
And then we have to think about the gallbladder and liver, right? Pain from there can show up in the epigastrium.
Exactly. Let's talk biliary issues. You have biliary colic, which is this intermittent, severe, deep pain. It's usually in the right upper quadrant, but patients often feel it in the epigastrium. The key diagnostic clue here is the trigger. It is almost always brought on by a fatty meal.
And why a fatty meal specifically for the gallbladder?
So PU pain is about acid, which happens after any meal. Gallbladder pain is about contraction. When you eat fat, your body releases a hormone that tells the gallbladder to squeeze and release bile. If you have gallstones, that squeezing action causes the intense colicky pain.
And what about the more severe version, cholecystitis?
So cholecystitis is actual inflammation of the gallbladder. The pain is more constant, lasting for hours, and it's also made worse by fatty foods. But what really sets it apart are the systemic signs. You'll often see fever, a fast heart rate, a positive Murphy sign on exam, a high white blood cell count, and abnormal liver function tests. All those things point to a serious inflammatory process, not just an ulcer.
Okay, and circling back to pancreatitis, we know to check the labs, but what about the patient's story? How does that pain present differently?
Pancreatitis pain is usually described as more severe, just exquisitely painful, and it often radiates straight through to the back. A classic clue is that the pain gets much worse when the patient lies flat and feels better if they sit up and lean forward. The history might also point you there, a history of heavy alcohol use or known gallstones. But at the end of the day, it's those sky-high amylase and lipase levels that seal the diagnosis. Now for the section that requires the most vigilance, because there are several life-threatening conditions that can masquerade as simple PUD.
Let's start with the scariest one, a heart attack presenting as stomach pain. myocardial infarction.
This is a classic trap, especially in older patients or patients with diabetes. An MI that affects the bottom wall of the heart, the inferior wall, can irritate the diaphragm. And the nerves from the diaphragm share pathways with the upper gut. So the main symptom might be severe epigastric pain, nausea, and vomiting, with absolutely no chest pain.
So how does a doctor avoid that trap? How do you tell the difference between a cardiac emergency and a stomach ache?
You have to look at the whole picture. In a high-risk patient, a smoker, someone with high blood pressure, if they have those GI symptoms, plus any red flags like sudden dizziness, sweating, shortness of breath, or their vital signs are off, you have to think about the heart. You have to get an ECG immediately. The pain usually has no relationship to meals and doesn't get better with antacids.
What about vascular problems in the abdomen itself, something like chronic mesenteric ischemia?
This is another great mimic of PUD. It's basically angina of the gut, hardening of the arteries that supply the intestines. So when the patient eats, the intestines need more blood to digest the food, but the narrowed arteries can't deliver it. This causes severe postprandial epigastric pain, pain after eating.
How do you differentiate that from, say, a gastric ulcer, which also has pain after eating?
The clues are in the patient's history. They are typically older, they have all the risk factors for atherosclerosis, smoking, high cholesterol, and they almost always have significant weight loss because they become afraid to eat. The pain is often described as just excruciating, a much more severe cramping than typical ulcer pain.
Are there other sort of vascular issues to consider?
There's a rare one called mesenteric vasculitis. This is when you have unexplained abdominal symptoms, maybe some GI bleeding, in a patient who has signs of a systemic vasculitis elsewhere in their body, like joint pain or skin rashes. It tells you the problem isn't just in the stomach, it's a body-wide inflammatory disease affecting the blood vessels.
And finally, let's revisit the one we're always trying to rule out, gastric cancer. What are the definitive signs that an ulcer might be malignant?
It really comes down to the persistence and severity of those alarm symptoms. A cancerous ulcer often causes profound, unyielding weight loss and anemia. The pain is usually constant and doesn't respond to the usual medications. While a benign ulcer can bleed, a cancer often presents with a whole constellation of systemic decline. The patient just feels profoundly unwell. And that's exactly why the EGD, which lets you biopsy the ulcer, is the mandatory non-negotiable step whenever you see those alarm symptoms.
We have covered so much ground, from the first symptom all the way to surgery. Let's finish up with the long-term view: prognosis, complications, and prevention. Once PD is diagnosed and treated correctly, what's the outlook?
The prognosis is actually excellent for the vast majority of patients. Once you treat the underlying cause, you get rid of the H. pylori or you stop the NSAIDs, the healing rates are very high, and the mortality from PD has dropped dramatically with modern medicine.
But that word recurrence keeps coming up. It seems like PD has a nasty habit of coming back.
That is the big challenge. Recurrence is very common. We're talking rates over 60% in many studies if the root cause isn't permanently dealt with. If a patient gets better but then goes right back to taking NSAIDs every day or smoking, that ulcer is very likely to come back. That 60% figure really underscores why patient education is probably the most critical part of long-term management.
And there was a specific statistic about NSAID users, a pretty sobering one.
Yes. For people who have to continue taking NSAIDs, the risk of a catastrophic event is always there. The rate of NSAID-induced gastric perforation, where the ulcer just bursts, is about 0.3% per patient per year. Now, that sounds like a small number, but when you think about the millions of people taking these drugs, it adds up to a significant public health issue.
So if it's left untreated or ignored, PUD is definitely not benign. Let's clearly list the 5 major serious complications.
These are the 5 outcomes that make PUD a dangerous disease. 1. Upper gastrointestinal bleeding. This is the most common serious complication and can be anything from a slow leak causing anemia to a massive life-threatening hemorrhage.
Okay, what's number 2?
2 is gastric outlet obstruction. This is when swelling and scarring from a chronic ulcer blocks the exit of the stomach, so food can't get out. It leads to projectile vomiting of undigested food. 3 is perforation, which we've mentioned. The ulcer erodes right through the wall, spilling acid into the abdomen, causing peritonitis, a true surgical emergency.
And the last 2.
4 is penetration. This is similar to perforation, but instead of opening into the abdominal cavity, the ulcer burrows into a neighboring organ, like the pancreas or the liver. And number 5 is the long-term risk of gastric cancer, especially with chronic, untreated H. pylori infection.
So given that high recurrence rate and how severe those complications are, prevention and education are everything. What's the key counseling you give to patients?
The main strategy is avoidance of things that injure the stomach. That means very direct counseling about stopping NSAIDs and aspirin if possible, eliminating or drastically cutting back on alcohol and stopping smoking.
Mhm.
Both tobacco and alcohol directly impair healing and increase acid. Limiting caffeine is also a good idea.
And for that person who has to take an NSAI.
The strategy has to be really strict. You use the lowest possible dose for the shortest possible time. And for anyone on them long term, you have to seriously consider prophylaxis, giving them a PPI or misoprostol along with the NSAID to protect their stomach.
Are there any other lifestyle factors that play a role?
Yes, obesity has a strong association with PUD, possibly due to inflammatory or hormonal factors, so weight loss is often part of the comprehensive plan. And while we know stress doesn't directly cause ulcers, stress reduction counseling can certainly help with managing symptoms and just promoting overall wellness and compliance with treatment.
We have just completed a very thorough deep dive into the clinical evaluation and management of peptic ulcer disease. We've established that the whole diagnostic path really hinges on spotting that key difference in pain timing between gastric and duodenal ulcers. That's the aha moment.
And we confirm that EGD is the gold standard, absolutely required for anyone over 50 with new symptoms or any patient with those critical alarm signs. We detailed the power of that triple therapy regimen, how the PPIs really enable the antibiotics to do their job and wipe out H. pylori.
And we saw that PD management is all about layers, from stopping NSAIs to aggressive medical therapy, and then finally, if needed, surgery for those refractory ulcers that just won't heal after months of treatment. We've really mapped out that whole clinical journey.
Now, here's a final provocative thought for you to take away, building on our discussion of the differential diagnosis, especially that terrifying high-risk overlap. We mentioned how knowing PUD forces clinicians in the ER to think about the heart.
So ponder this. Just how critical is it for a clinician to be able to tell the difference between chronic after-meal epigastric pain, the classic sign of PUD, and the acute, sudden epigastric pain of an inferior wall MI, a heart attack? The decision between just refilling a prescription and rushing a patient to the cardiac cath lab can literally hang on noticing a few subtle clues. The patient's risk factors, whether they're dizzy or short of breath, whether their vital signs are stable.
It's the ultimate example of how, in medicine, the most common presentation can sometimes hide the deadliest disease. Knowing the ins and outs of PUD really prepares you to look beyond the obvious and see the whole patient.
Thank you for sharing your sources and for diving deep with us today. We hope you feel incredibly well informed.